So I wanted to say welcome to everyone to the Allscripts user group. We are doing the quarterly user groups again, and hopefully this is going to be helpful for all of you here. I appreciate your support, and tonight we're going to be talking about a few things. I did want to just go over a few points about the 11.4 upgrade. We are going to be talking about a new module that we're going to be starting up. It's primarily for primary care, but it's I think it's going to be having some applicability to the specialists as well, especially for OB/GYN, so that's the patient-centered care module. In addition, there is some question about surgery content updates, and we probably don't need to go over that since I think the urology doctors already have kind of gotten up on that. It may be helpful for gynecology, so what do you think if we can go over how do we do pre-op orders, and then there's a pre-op history and physical outputs that you can go ahead and print off and send to the pre-op holding. Finally, we're going to be talking about the Medicare wellness visits, and AKA the $310 office visit. So if that's a little bit intriguing, it's primarily again for the primary care doctors. So, but at some point we're going to take a little bit of a break, and if you don't feel that the Medicare wellness visits are on the are important enough for you, and you feel like you need to duck out, that'll be a good time to let you go ahead and take off. But it'll be something that we'll want to go through and review the workflows of how to do a Medicare wellness visit, because the reimbursement is significant. And those different visits are the initial preventative physical exam, and then finally the annual wellness visits. So in terms of the 11.4.1 update, just to let everybody know, if you aren't totally aware, Monday is our go live date for the 11.4.1. We are going to be having everything shut down on Friday at 11 p.m. So remember to get all of your charges sent over and kind of done, and have your office managers bring those over into the PM system, because they're all going to get crazy after 11 p.m. on Friday. It will be unavailable, so don't plan to be able to do some chart work on the weekend. It may come up Sunday at 6. It may even come up sooner than that. So if you don't see it until after 6 o'clock, then that's you know that they're having some troubles. But we don't think that's going to happen. We think they'll be up before Sunday at 6, but that's their kind of estimated time. Talked about the charging counters being submitted. And then also, along with the upgrade, we're going to be having everybody have the opportunity to be able to send lab test orders out through the interface to Quest Lab. And that's anywhere up to San Luis Obispo all the way down to where, Stan? Down to LA or San Diego or somewhere? So we have a pretty broad region where people can go to Quest. The interfaced orders will go out, the results will come back into the patient's chart. We've already been piloting it. It's working very well. Dr. Men's GI has gotten even some path results back through the interface, so there's some significant improvements with that. So that'll make lab orders much more robust when we're getting those results back on as discrete results. So let's talk a little bit about this patient-centered care module. The idea, it is going to be coming on probably in the next month or two, and primary care providers are going to be the ones who are initially going to be trained on how to use it, but then other people will be able to use it as well. The module also will assist with the accountable care organization, the Medicare Shared Savings Program. So whoever's participating in that, and I think everyone here will be, some of those measures are going to be the measures that will be looked at through this program. So care measure review, it's kind of like the meaningful use quality, continuous quality measure portal, where you saw the little dashboards of the red and green and how well you're doing. And it's working quite well. There's a few measures that we had some difficulties getting everything linked up, but it looks like it's doing pretty well. So This is going to be able to help with tracking and reporting of meaningful use, PQRS, the NCQA program, and the Medicare Shared Savings ACO program. And then one of the really, I think, unique new developments with this is that there is a schedule portion to this program. It allows your medical assistant to look ahead maybe 2 weeks before a visit, before a day, and review all the patients who are coming in for that day to say, do they need a pneumonia vaccine? Do they need a mammogram? Do they need their weight counseling performed during the visit? And so you can do some advanced pre-visit planning. And let's say they need to have their hemoglobin A1C. It hasn't been done in more than 3 months, and they're a diabetic with high A1C numbers. So let's go ahead and order the A1C, have them go to the lab and get it, and by the time you see them, it'll be they'll have the result, and you can address that during the visit. So I think that this is something where we're going to be seeing that even though there is some extra work in setting it up and looking at it, this is a way for us to take better care of our patients. And I've really already started to see that in my own patients, in my own practice. And the initial piloting of this program that we've done in our office with my medical assistant doing some pre-visit planning and jotting down notes of things that needed to happen has really been successful for us. And so my numbers are starting to look better even already. And again, also in addition to that schedule where you can look ahead and look into these measures at the point of care. So then I'll go ahead and click on the dashboard view, and I'm going to show you a little bit of that right now. Let's just jump into the module, and let's see. So this is a patient of mine, ZZ Johnny Carson. Actually, let's go to Justin Bieber. So when I'm seeing Justin Bieber today, he's sitting in my office in front of me, I can just select this little dashboard button up here in the upper right hand. You guys don't need to see the little laser pointer, do you? I think we're just going to go ahead and you can follow me along. But if you click on this dashboard link, it will open up the dashboard for this patient. And as you can see, there's a lot of measures that we need to take some care actions for. The patient will be assigned to certain populations based upon whatever diagnosis either you've assessed or diagnoses that are apparent because of the fact that the patient's blood pressure is really high, so maybe they have hypertension, or their blood sugar was 200, so maybe they've got diabetes. So with these populations being addressed, then some measures are automatically assigned to monitor the patient and how you're taking care of the patient. So you can see that, they have hypertension, but I didn't give them a prescription for the blood pressure. And maybe you chose not to, but a lipid panel should have been performed. And because of this person's age at 68, not having a pneumonia vaccine is a little bit of a problem. So those are all issues that I can address right now, and I can just go ahead and order those things. Preferably, my medical assistant will have already done all of this. And that is the value of all this, is because a lot of this can be done pre-planning, pre-visit work, and my patient, when I walk in to see the patient, they will have already been given the pneumonia vaccine and the flu vaccine. Question, Stan?
Yes, so a few weeks before the visit, does the medical assistant go into the dashboard and look at this list to make some of those determinations?
Yes, that's what we do. Let me go ahead and see if I can.
Protocol.
There is a protocol by which we can do that, and I can go ahead and bring up a different dashboard. Well, actually I won't, because it has live patient data. The question is does my medical assistant then go ahead of time into the dashboard to be able to look at this patient and all the rest of my patients for that day? That's the schedule function of this module. There's an actual schedule that mirrors the schedule that you have on your Allscripts. So when you go to your daily schedule and you see all your patients listed, there is a mirror schedule in this module that your medical assistant can look ahead 2 weeks, 1 week, the day before, because you may have had some patients added to the schedule up until the day before. So it's good to do another last check to make sure that you've dealt with all the patients who are coming in and to try and do this. And again, it's so much easier to deal with these care goals when the patient is in the office visit with you than to try and mail them letters or to call them to come in and get their pneumonia vaccine. So this is, it's been fantastic. But there also is another aspect of this module to allow you to create these what are called pursuit lists. And pursuit lists will then be able to look at all of your diabetics who haven't had their A1C in the last 6 months. And then you can go out and mail merge that list and send all those patients the letters that, you know, we really need to see you, your diabetes hasn't been checked lately, and we would like to have the opportunity to confirm that your diabetes is under good control. So that's, in essence, that is this patient-centered care module. Again, you can see the benefits for primary care, but there are a lot of other specialty measures that will be coming on board, and they will be appropriate for specialists as well. Another question, Janice?
So the MA writes an order for a lab test, and whose login does she do that?
It's, okay, that's a good question. So the question is if the medical assistant identifies that a patient needs an order for pre-visit planning, like a hemoglobin A1C, so, or a PSA.
Even a vaccination.
Or vaccination. So in the same way that they have protocol type orders where they can place an order and then it'll come to my task list to authorize that. I am now getting many tasks a day because a patient will be coming in, you know, next week, and we want to get some lab tests ordered or other things like that. So my medical assistants now are starting to, based on a protocol that we have set up in our office, to be able to do that. And so at the various clinics, there will be some workflows that they will be working on to try and address that. And so I think you can be, you know, again, as this becomes more and more applicable to your own offices, you'll probably be getting involved in this and having the opportunities to see these benefits. So I really encourage, like for OBGYN, you do a lot of kind of primary care for some of your patients, isn't that true? So I think that it can be a real windfall for you, and I think that so I think that's all I wanted to say about this module. Any questions about that? Okay. I think because of the audience that we have here today, we're going to probably just leave the surgery kind of surgery scheduling workflows for later on in our meeting. And you know, if you want to stick around for the entire meeting, you can stick around for that if you think that's going to be beneficial. But let me get back into our agenda here, and we'll move on to our next discussion, which is the Medicare annual wellness visits. Actually, you know what? Before we do that, let me back up a little bit. What do you all think about the kind of hearing about how surgery can work and how that can best be used? I think, Janice, you have probably more experience than anyone else here in terms of actually using those workflows.
You're talking about the surgery pre-op.
The preoperative,
history,
yeah. Let me go through
order.
what I mean by that. Do we want to go ahead and talk about that a little bit, or?
Yeah, I think it would be valuable.
Yeah.
I'm interested in it.
Yeah, I think it'll be good for the you know, for us to review this, and in as much as this may be helpful for some of the surgeons who may be watching the video. So let's go back. Okay, yeah. So one of the other workflows that I wanted to review tonight was the surgery scheduling workflows. And there's several documentation tools that are available in the system for surgeons who are seeing a patient, discussing a potential planning for a surgery, and going to be doing that as either an outpatient here at the hospital or maybe even inpatient surgery. But you're discussing all this and you're setting this up. Well, at that point, you have a lot of work to do to set up the preoperative orders, to make sure that all the preoperative testing and medical clearances have occurred, and then finally to make sure that a history and physical gets over to the hospital so that they can log that for the patient and have that be available on the day of the surgery. So it's the thought was that if we can develop tools within a V11 Allscripts note that could take care of all of those processes, and then that would make things more efficient than having to generate a note for today's visit in Allscripts and then going to a surgery dictation, hospital dictation program to dictate the history and physical, and then pulling out a preoperative order sheet and writing all that down, and then somehow getting all that information back into the Allscripts chart. Why not just have it as part of the one note when you're seeing the patient that day? So what we elected to do, and really the urology doctors and their nurse practitioner helped us to pilot this. And what you have here is just a regular note. It's a urology note for our patient, our test patient here. And if you see in our note, I'm not going to go through everything here because you all are familiar with this documentation, but this patient has benign prostatic hyperplasia. So we filled out a chief complaint, history of present illness. We did all of the surgical history, past medical history. And then after doing the assessment and plan and deciding, yeah, you know what, we're going to go ahead and plan for a transurethral resection of the prostate. And so we want to set up that surgery. At that point, if you are a surgeon and with the surgical specialty notes that we've created for you in the Allscripts system, you will have a preoperative order where you can open this up and you can start to document the types of information that is needed for a preoperative history and physical. So you can put in the date of the surgery, admitting diagnosis, what the consent should read, who you want the primary surgeon to be, and if there's an assistant. So basically you can just type that in, and then all the other information that's needed on that, the yellow form for the preoperative orders. And what's nice about this is that you haven't had to go somewhere else to look for it. You still have to spend the time clicking these boxes, but now it's actually a part of your note. And we have created an output. As you know, that there's all these different outputs that you can click in order to be able to generate a consult note, or here's a return to work note. So obviously if you're going to be performing surgery, the patient probably isn't going to be going back to work or during that time. So you can generate a work note. You can generate a consult note. And this is the output for the pre-op order. So if you, as we take a look at that, we can view what those look like. So here's the consult note to tell me that my patient has been seen by the urologist and we're planning on surgery. And then a copy is sent to the cardiologist. In addition to that, here's the pre-op orders as they were generated in the documentation tool. Here's the return to work note. So let's close back out of that note, and you can take a look at what the outputs actually look like, because in the end, that's all that really matters, right? Is what do these outputs look like, and are they useful for people to get information? So you can fax this. This established note here is the actual note that we generated that we were just looking at. So you can fax it, but let me just show you the print preview so you can see what it looks like. If you select that note and you click the pre-op H&P, that's the history and physical, it looks something like this. Community Memorial Hospital preoperative history and physical. And when that gets faxed over, that can be used as the history and physical. So instead of having to go and recreate an additional kind of dictation of your entire visit and the preoperative counseling and the decision to move forward with the treatment plan, you've already done that in the note. Why not just use that as your history and physical? It has all the elements that are required, including past medical history, surgery, surgery history, and all of that. So if you can fax that over as your preoperative history and physical, that's kind of a win. And I think that the general surgeons can do that as well, but we're going to need to develop the tools for the general surgeons. They haven't had their note forms updated. So we'll be working on that in the near future. In addition to that output, which is the history and physical, we showed you the consult letter. So if you look at this brief consult, you can send that out, and that's kind of nice. A lot of the specialists like to send out these letters. So that was the brief consult output. And then finally, the preoperative orders output. So let's show you what that looks like. Now again, the way to get these to come out looking the way you want them is to pick the print template. So if you see this print dialog box whenever you're printing the document, and instead of the typical one that I use, which is what I'm defaulting as my letterhead with logo, I can move it down to pre-op orders print template, and then I'll show you what that looks like. So now it says Community Memorial Hospital doctor's orders, preoperative orders. And again, that is almost exactly what that yellow sheet looks like. And then it has the patient's name, date of birth, the date that this was generated, and then also the preoperative orders. And you can actually read them. So I think that the, have you had any response with these surgery?
We're using them all the time.
Okay, and how is that going?
Okay, the only funny thing about it is our surgery coordinator, I don't know how many times I've told her we have a surgery scheduler. She doesn't get it, that when I attach those to the pre-op, that is the orders. She still comes to me with the original yellow sheet.
That's interesting. Okay, so what you're saying, Janice, and just to review for the video as well, is that there is some challenges that people are not understanding that this actually is the
Right,
preoperative
and
orders. They're looking for that yellow sheet,
Yeah.
but you don't need to because this is here. And again, if you have done this within the note, this is already saved in their chart.
Right.
So you don't have to scan it in and review it or sign it or do anything like that. I think it's much more readable, and as the nurses are putting these in, this is probably going to go away though as we continue to move forward with our efforts for computer order, the physician computer order entry. So that's going to be something where this may not be necessary off into the future. But at the same time, for right now, this is has been a good bridge, I think, to help some people to be able to do that.
You mean eventually we won't even bother with the paper
No, you're not
aspect?
going to be allowed to do it.
That's right. Well, so and that'll be a good thing, but at the same time, again, a bridge was helpful. But at least we can say that the note will continue to be a acceptable document for the history and physical, the preoperative history and physical. And I think that that's going to satisfy a lot of the surgeons' needs to be able to directly distribute those documents to whoever needs them in order to prepare the patient for surgery. So that's the preoperative workflow. There's also post-operative notes that we have built that are very helpful as well. And so if you look at when a patient comes back after surgery, you want to, as efficiently as you can, you want to be able to document their post-operative course. So there are post-operative history of present illness forms that say, okay, well this is the routine post-op visit, the surgery performed was the TURP, and since you have this in the history of present illness, if you select a new note, a new post-op note, we'll go ahead and just do that real quickly here to demonstrate that what's nice is to be able to bring in a previous history, and all of the history details that you've documented at the initial post-op visit, you can just bring those in again and say, yeah, it's pretty much the same thing. And so you can say previous history, and already you have the surgery date, what the surgery was performed, and now you can go ahead and say, well, now what are your current symptoms? Well, are you still having burning with urination and frequency? No. So all of that is improved, and the malaise and the anxiety has gone away too. But you know, they're having maybe still a little bit of hesitancy. So you can make adjustments with that. The post-op exam is again something that's hopefully very quick and you know, easy to document. If there was a abdominal incision for the urology procedure, you can do that. There are post-op exams for general surgery. So general surgery is using this one, and we can create one for GYN surgery post-op physical exam. But you'll see that it includes both things like the constitutional information, details of the wound, because that's usually important, and then we have our other you know, the rest of our exam, like you can, if you did a heart and lung exam, you can go ahead and click those exam findings as well, either documenting the normal, or you can document an abnormal, you know, tachypnea and you know, using accessory muscles and a little bit of distress, and so you need to go send them for a venous Doppler. Does that make sense? So that's again, hopefully elements of the documentation for the post-op note that are going to make this a lot easier. And we even included the preoperative orders because it's hopefully rare, but sometimes you have to go ahead and take the person back for another procedure subsequent to that. So we wanted to make those tools just always you know, readily available. So any questions or other comments? Janice, what else about your experience with the pre-op or post-op?
It's really helped. It's you know, certainly sped things along in our office for flow.
Okay. So and have the urology doctors have
Yes.
they been using it as well? I know
In
you
fact-
are doing a lot of the pre-op history and physicals,
Right,
but are they using some of
sometimes a
that?
patient is seen that day and they're put on the schedule that evening or the next day, and Dr. Beegler put one right on for tomorrow and did it all himself, and it was beautiful.
Okay.
It turned out beautifully.
So just for everyone else, Janice was saying that in her office, the urology surgeons were able to just very efficiently set something up for that night or the next day, and to be able to have all this documentation at the ready. You don't have to wait for a pre-op history and physical dictation to come from the dictation program. So you have this right now, and you can generate it, you can print it off, and you can hand carry it over to the hospital if need be. So it does allow for some more flexibility. It probably won't work for everyone, but it is something that as these solutions are available and more people find that it is helpful for them, I think it's definitely worthwhile for us to try to work on these kinds of documentation tools. So I really want to put this out there for everyone, for all specialists. There are new things coming in with the new version that we're excited about, but we haven't stopped the process of content development. So if there are more V11 note content issues that you really need to work on, please work with us. There are a few specialties that we're still working on and going to be working to improve. So general surgery is one of those that we're going to be giving some upgrades to. I think we still have to work on dermatology, gastroenterology, to name a few. So stay tuned.
So, a couple of questions. What do you do with copy forward? Because I still find that it breaks on our custom forms. And so you don't find that a problem right now?
Breaks, what do you mean?
In other words, you don't see the form. It's not a form that was created by Allscripts. At least that's what I've seen sometimes with the use of copy forward. That it seems to be more
Thanks. Yeah, let me rephrase the question. So with V11 Note, the documentation tools, one of the tools is a copy forward function. And if you can see down in the bottom middle, this copy forward button may allow you to go back to a previous note, say the pre-op visit from August, and I can select a few forms that I can bring forward. So here is the, let's go ahead and bring forward the review systems form and the exam form, and maybe this one on impotence. And then here's the pre-op, the referral consultation letter. So let's bring all those forward. And as you can see, a lot of that still does work. Here's the consultation. So that says, I had the pleasure of evaluating your patient for erectile disorder. So the point that's being made is that this works sometimes, and it doesn't work sometimes. And when it doesn't work, it's obviously very frustrating if you're relying on that. And then, if not, then you obviously have to work through some alternative way of documenting. So you have to kind of start from scratch at that point. But I will say that we'll trade one frustration for something that has the same questioner has been really excited about. You can see this red line underneath the misspelled items. So you can see that even in real time, in this the compiler, the misspellings, I obviously misspelled a few words there, and but that works. So in any place where you'll see a text box where you can type in text, and if you misspell it, you will be able to see that red line there. Now, as you're typing, it won't automatically turn red, but it kind of pops up later, or sometimes it will, if the bar I have noticed this, if the bar is narrow enough and it doesn't allow you to even see a red line underneath the text, you may miss it. So don't rely on it. Obviously, it's there as a tool. The tool is only as good as how you use it, and it can be misused, or it can be frustrating, and how many people have hit their thumb with the hammer. So we're always going to be facing frustrations as we're trying to deal with the documentation, both in these forms, but then also the documentation that people are using Dragon. And how many mistakes have we all come across, both for ourselves as well as our colleagues with Dragon? And so I don't know of any perfect solution, and but we can continue to try and move these the vision forward for having easier, more efficient documentation, continuing to use templates to get most of your work done with one click is a great goal. And I don't think that there's anything that's inappropriate, as long as you are making sure that the content that you're generating with those templates is actually accurate and appropriate for the patient's encounter. So, well.
And then the second question was,
okay.
What do you do about your 35-day-old history and physicals?
Copy form and update them.
Yeah, we update them, absolutely. Sometimes it means bring the patient in for another course of vital signs,
Okay, so the question is how do you do if the pre-op history and physical was, or that visit was done before 30 days before the surgery? You need to have a updated history and physical within the 30-day window. So you bring the patient back, and again, if you are able to use the previous history button, then I would by all means try and do that. If you can do the copy forward, that may be even a better solution. But again, that copy forward, just be aware that it doesn't always work. You can go back to the previous note, select whichever note forms that you can see that are available, and if you don't see a note form available, you're pretty much left with just having to recreate that information and documentation. Okay, well, then let's go ahead and move on to the rest of the talk for the Medicare annual wellness visits. Okay, so we're going to go ahead and go on to our next topic, and that topic is the Medicare annual wellness visits. And as I alluded to in the beginning of my talk, also known as the $310 office visit. So we're going to, hopefully that piques your interest, because there's a lot of primary care providers, internal medicine doctors, family practice doctors, the nurse practitioners working for those providers, and also some of the OBGYN and maybe some other specialists. I know some cardiologists who are doing a lot of primary care as well. So in this new realm of the way that we're providing care, Medicare has decided that they're going to focus most of their efforts on function and prevention. So if you get those two words and wrap your head around those two words, you're going to really be able to understand what we're trying to do with Medicare annual wellness visits. But Medicare, up until now, has not paid for any kind of a preventative health visit or a physical exam. And we've just kind of had to basically try to document the problems that patients had and bill for visits, usually on a evaluation and management code basis. But now Medicare is paying for a lot more preventative services. And in 2011, they developed a list of preventative services that are available. Those will include things that they've always provided for, including pneumonia vaccines, flu vaccines, PAP tests. But now they're going to be providing, kind of a full comprehensive list and getting the word out to patients. So a lot of your patients now are hearing, well, I should be eligible for all of these kinds of things. And in fact, they can go to a website and look at what preventative services they are actually available to. And your office manager can go to a portal with the Medicare carrier that you are signed up with to put in a patient's name and demographics and look and see, are they even eligible for a mammogram at this time, or when will they next be eligible? And my office manager printed off for one of my patients a test kind of a case, and there was this entire list of preventative services and when this person was eligible to get that next preventative service. And it's very helpful. So annual wellness visits are provided for under actually the Affordable Care Act of 2010. And it's allowed once per year. Now, many of you heard of the initial preventative physical exam, or the Welcome to Medicare visit, as it has been known to be called. And a lot of doctors haven't gotten the message, however, that now you can do one of these every year. So they are actually now being called annual wellness visits. The Medicare coinsurance and Part B deductibles do not apply for these visits. Meaning, if a Medicare patient has a deductible of $250 and they have a coinsurance of 20%, none of that will be charged to the patient for the visit. Now, some of the preventative services that you refer them to may carry a coinsurance, but these visits do not. So you can proceed to tell your patients, you know what, you will not pay a dime for this visit. Now that's important because the actual components of these annual wellness visits are not necessarily things that patients have come to identify as I'm going to go in and get my history and physical and I know what that means, because it's different. So bear with me as we go ahead and talk a little bit about what that means. But there are certain requirements for the annual wellness visit. There's an establishment of an individual's medical and family history. So their medical history and their family history. Well, most of that is already in our patients' charts, right? So that's nothing new for us. And in most of our patients' cases, it's already been done. There is the need to establish a list of current providers. And now with the version 11.4, that's actually a lot easier to document in the patient profile. If you know what the I is in Allscripts, and we'll show that as we go through the system and kind of go through the workflows. But you can list your current providers. Let's say they have a urologist, they have a cardiologist, and they have a podiatrist, and you as a primary care provider. So
gynecology.
all of that information can be documented. In addition to that, and some people will include the visual acuity as kind of a functional assessment, but that doesn't seem to be required in all cases when they talk about these wellness visits. But so any other routine measurements that's deemed appropriate to the patient's history and their family history maybe. We also want to look for cognitive impairments. So if they're having difficulties with dementia or confusion or other things that are going to affect their functional abilities. In addition to those, there's the looking for risk factors for depression. So we've, for NCQA, many in the Centers for Family Health have already been asking the adult physicals and even the adolescent physicals these two questions for risk factors for depression. So that's a part of the one of the components of this visit. In addition to that, there's reviewing their functional ability levels, including their activities of daily living and their IADLs. Extra brownie points to anyone who knows what the I means. Raise your hand, raise your hand. I'll call on you. Okay, Janice.
Instrumental?
Instrumental activities of daily living, yes. Okay, so instrumental activities of daily living, and we'll go through just real quickly what those are like. Now, this seems like it's a lot of information that you're getting from the patient. Also, we want to talk about screening and prevention measures. So screening for osteoporosis, breast cancer, prostate cancer, a lot of other kind of, maybe even abdominal aortic aneurysm in the case of males over the age of 65 who have been smokers. So you should think about doing a abdominal aneurysm screen with an ultrasound. Other things are the personalized health advice as related to those preventative counseling services that you're recommending to the patient. So you need to give them a written printout of a sort of prevention, a personalized prevention plan. And that is a required element. And so, you know, this starts to be a lot, you know, goals, weight loss, physical activity, smoking cessation, fall preventions, nutrition, other kinds of recommendations, and all those, when do you need your next bone density, when do you need your next flu shot, and all of that. So it ends up being a lot to be able to do in a 25-minute, 30, 40-minute visit. And for that reason, many primary care providers are just choosing not to provide this service. And it really hasn't been widely adopted, unfortunately, because in the end, the patients that I am doing this for, they really do sense a benefit, that we are really looking now and trying to take care of their functional abilities and their quality of life and looking down the road. Because again, you have most of the things like their high blood pressure and their cholesterol pretty well dialed in by now. But let's look down the road for you. And you can talk about, one of the other required elements is to discuss the end of life and what the documents that they need to be putting together, like either the POLST form or their advanced directives, so if they have any of that. So it's important for you to discuss whether they have that, if they can provide that for you to be put in a chart, and if they have any specific wishes for their last season of their life, and for you to be able to provide them some opinions on whether you agree with that. Is that appropriate? You've got a lot to live for. It's, we don't think that you should necessarily be comfort measures only at this point. Maybe you probably do want a antibiotic if you get a bladder infection. So, those are some of the things that you may want to counsel them about. And there's a lot of misconceptions about end-of-life care, and you can really start to address some of those kinds of things. So let's talk about the actual types of visits. The first one is the initial preventative physical exam. And what that is it's allowable once per lifetime for each Medicare beneficiary in the first 12 months after they become eligible. So let's say their birthday is November 15th of 2013. They will become eligible on November 1st of their birthday month. And within that first 12 months, up until October 31st of 2014, they will be eligible to receive this initial preventative physical exam. And there's some extra little goodies that they get as a part of the first one. But, so that is one of the things that you can, one of the services that you can provide. The code for that, CPT, actually it's a HCPCS code, G0402, pays $179. So that's pretty good. That's a lot better than the maybe $130 or $150 that I might get for a physical exam, especially if they're an established patient, with most of the insurance carriers. And since Medicare doesn't pay at all for a preventative visit, it's a lot better than that. So the best I could usually do for my Medicare patients legitimately is to do a 99214 unless they had some life-threatening condition, and even that doesn't pay nearly approaching that. But what's interesting is that and there's some other kind of aspects to that. The end-of-life planning, the ultrasound is one of those extra goodies that I talked to you about. So for males greater than 65, it is a covered benefit, although their co-insurance does apply with this. So it's only 80% paid by Medicare. But if they want to go ahead and add that to their medical services, they can get an ultrasound for screening of aneurysm. Same thing for the EKG. So in my office, I'll do a $20 EKG. I'll do the $179 HCPCS code. And in fact, I'll probably talk to them about their diabetes, their hypertension, and their hyperlipidemia, which is a 99214, which for me pays about $110, $111 last I checked. So that's, you add that up with, that's $310. And I can usually get that done in about 45 minutes if my medical assistant helps me out. Some of the medical assistants in our enterprise are able to do some documentation of history of present illness, especially if they're just transferring over information from a sheet that a patient has filled out, a questionnaire, what we call a health risk assessment, that the patient will fill out before their visit. And then I come into the room, that's all filled out into the chart, and I do the brief exam and reviewing of all that, and discuss their preventative services and document that so that they can have the printout. And then I'm on to ordering labs for their cholesterol and their diabetes and other things. So that's how you can legitimately get that kind of reimbursement. And it really is a powerful tool for the patients as well. And we'll see some of the aspects of that. But so as I said, when you do bill an E&M code along with this, you have to attach a modifier 25 to the 99214 code. And that just allows you to have a separate billable service at the same time. Okay, let's talk about what's the next one. So after that first 12 months, now it's the second year of their Medicare. And so whether they had an initial one, the IPPE or not, but they're in their second year, you can perform an annual wellness visit, initial. And that is pretty much the same as the IPPE. What it says here is that you can't bill that until after the first year, but again, it can only be billed once per lifetime. And but it doesn't have to necessarily be the second year. It can be the 5th year or the 10th year. As long as they've never had an initial annual wellness visit, you can do that. That actually pays more. It's $186. But you can't do the ultrasound for the aneurysm, and you can't do the EKG, at least not unless it's clinically indicated for non-screening, actual medical conditions. So you can do an EKG for other reasons, but not for screening after that first year during the IPPE. So again,
that's the first year you're eligible, because that's only the 65 year. If you're 67 when you show up, there's no way that patient at age 67 can get the initial screening coverage for
you can't get the IPPE, but you can get this visit. This would be the initial annual wellness visit. And again, you can bill this visit along with another E&M code like a 214 or a 213, whatever is appropriate. And then finally, after they've had their initial annual wellness visit, any subsequent year, you can continue to see them. You can continue to perform a similar service, the same service essentially, and doing just follow-ups on all the issues that you discussed in previous years. But it's it can only be one per year. So you have the calendar year, and you can go to the Medicare carrier website and find out when they're eligible next for another annual wellness visit, and that's when you can schedule it again. This only pays $124. So, but that's still pretty good when you can combine it with an E&M code. So, as you can see, this can significantly augment the reimbursement for providers who are caring for Medicare patients in the primary care setting. And there are some tools that we then set out to build in Allscripts to be able to make this process much more efficient and actually, kind of workable. Because we don't want to fall out of compliance with the requirements, because if you can't survive an audit, then nothing else matters, right? But yeah, so just to let you see, this was actually a screenshot. The patient data, I think, has been taken off, hopefully. So, but this is the bill that I sent off I saw him for a couple different things. And that was the 214 visit with the little modifier 25 there. And then under that is the G code, the annual wellness visit. So this is these codes are active in our system. We can bill them. I've already gotten paid on many of these, and it's really amazing to see those kinds of claims coming back to you, and it actually is as much as they said that they would pay. So it's hard for me. I do some procedures in the office as a primary care doctor, but it's hard for me to routinely get reimbursements like this when you're not a specialist. And so this is, I think, a big boon. And it's also, I think, very helpful for the patients. And we'll see how that works. So any questions about just the vision for what this is and why this could be helpful?
Do you
Yes.
include your V70 visit, even though you've been already looking at a number of other necessary services? For example, there's
Yeah.
hypercholesterolemia and maybe hypertension might be thrown in there.
Correct.
Should you even put a V70 code? And if so, what's the benefit of doing so?
Well,
because you're just telling them, well, you don't really need that. I mean, that's my way of interpreting a V70
that's a good
code.
question, yes. So as most of you who have dealt with Medicare up until now has never accepted V70 as a code for anything.
Exactly.
So when you order
Dings
laboratory
are charged.
studies, you have to associate them with the diagnosis code. So if you order a lipid panel, you actually have to assess like a hyperlipidemia problem or something like that. V70 is useful for patients with regular insurance, especially PPO insurance, because that is how the insurance company will, if you link their annual visit, the preventative maintenance visit to V70, then the insurance company will pay the entire visit in most cases nowadays. They won't pay for it if you link it to their cholesterol and other things. So V70 is still a very important code for the fee-for-service insurance products. But for Medicare, up until now, this hasn't ever been used. Now what the recommendation then is to use a V70 for the annual wellness visit codes. You link that as the diagnosis. Now you don't have to. In fact, if you look at the Medicare, the CMS website, they have a kind of a Medicare Learning Network website, and you can go there and get a lot of information about all these things. They actually have documentation that says you can apply any code to the G codes, including if you just saw them for cholesterol and hypertension, you could just use those two codes, link it to the wellness visit, and then you'd be done. But in our office, we have chosen to use the V70 code because it really alerts my biller person to be able to know, oh yeah, okay, look at this. This is that one code that we need to keep track of, and so we do some analytics on those, and so it's easier for us to find the V70 codes than to when they're just all mixed up with all their other codes. Another question?
maybe this is beyond the scope of your presentation, but when you're documenting this visit, do you do a Bolstein mini mental or something to determine cognitive impairment? How are you addressing that requirement that you've met that?
That's a good question. What's interesting again is that since this is not considered a physical exam in the eyes of Medicare, and it is confusing for patients, and somewhat confusing from the standpoint of, well, if I'm going to have to pay money for this visit, why do I want to, if it doesn't even include a physical exam?
Yeah, you're not going to touch
Well,
them?
you can tell them that you are not actually paying for this visit. It is completely covered, but it is focusing on prevention as opposed to other things. So if you do have hyperlipidemia and hypertension, you probably should listen to their heart and their lungs and check for edema. The preventative services of a digital rectal exam for a prostate exam, that is a separate billable code. A female, like the pap smear and pelvic exam, there's a G code and a Q code. And I didn't know this, but it's about, I think that's about $70 or $80 reimbursement for those codes. I'm getting that. Lois, you're not getting that.
We don't get very much for
Yeah, we've gotten, we've gotten about that. So you may want to talk to my office manager and see about that. We can.
it. Dr. Green will tell you that his manager came through and said he can make all this money doing it.
Well, that's
that was not true.
well, yeah.
But
So
maybe it's changed now.
things are changing now, and it really depends upon how you're billing it. And a lot of rejected claims come back, so you do have to be careful about how you do the billing. But my office manager does have some billing tricks, so you can always get a hold of me, or you can also talk to the billing person with the Centers for Family Health if you're within that clinic system to be able to kind of find out what the best way to bill for some of these codes are. But so all of those separately billable services, that's what you want to use for that. But you really I was very surprised and shocked, and that was another reason I think why so many primary care doctors did not start implementing this. Oh, this isn't even a physical exam. It doesn't include a neuro exam. It doesn't even include necessarily a cognitive exam unless you've identified that they have a cognitive problem. So there is a recommendation at that point to stop what you're doing.
Even
No, I'm sorry, just let me finish, Janice, but I do want to get back to your question. So at that point, because this is a very important point, if you have identified at that point that they do have a problem, you should, what the recommendation is to then refer them for services for further evaluation of whatever problems are uncovered during this visit. You make them referrals, even if it includes you having them come back tomorrow or next week and saying, now we're going to talk about your memory and some confusion, and we're going to be doing a mini mental status exam, and we're going to possibly refer you to a neurologist or for some PET scan or some other thing like that. Well, that is all taken care of by this. So there is a mechanism, but for those of you who do CHDP exams, you also know that when you uncover something, you just provide referrals to go get something else done, and that's how the CHDP service works. Well, it's a very similar service now for seniors.
Okay, I get it.
Does that answer your question?
Yeah,
Okay.
I understand that.
Okay, thank you. Thank you for bearing with me. I don't want to kind of overtake what your questions are, but yeah, another question.
Yeah, so say I do one of these exams and then Chuck sees the patient 6 months later and he says, wow, this is a great opportunity. I'm going to do one of these exams. He does the same exam I do. Who gets paid?
Well, you have already gotten paid. And anyone who, including you, who tries to bill it within another 12 months will get that claim rejected. So it is best to confirm when scheduling this visit that the patient has not had this done. In fact, we had our first patient who we were planning to do, it was actually my partner, and he was planning to do an initial annual wellness visit. She was 68. So she couldn't have the IPPE, but she could have the initial annual wellness visit. Well, when he got into the room and talked to the patient, she said, oh, well, this is my second one, because my previous doctor had already done one last year. So there are a few doctors in the community who are doing this. And again, if you go to this Medicare contractor website, put in the patient's information, your office manager will be able to determine whether the patient is now currently eligible.
That's a good website to know.
It
What
is.
is it? How do
What
you-
is that website?
Yeah, how do you get there? What's the portal?
I don't know. My office manager
Email
did
it to us.
My office manager did it, and what we were actually going to be doing as a supplement to this talk, we are going to actually be putting out a full tips and tricks, basically a, what do you want to call it, a brochure about how to do this, how to be in compliance with this. But I do have something for you, and Stan, if you could pass these out. This is just an article from the Family Practice Association, AAFP, and it's how to do it. So it's a lot of the nuts and bolts. But let me go into the system and show you how to do this. Before I do that, let me just tell you what the documentation tools are for the annual wellness visit that we have created to be able to get the work done. So there's a health risk assessment form, and let me show you what that looks like. And bear with me, I thought I had this. Wellness visit questionnaire. So what our office is using currently, and what we're going to be, what the Centers for Family Health will be developing is something similar to this, is something that we give out to the patient. This is their homework. It's a 3-page questionnaire. Most of the questions are very easy to answer, but it talks about risk factors. Here we go: osteoporosis, HIV, smoking history. In addition, you have alcohol use questionnaires, questions, diet and exercise are good functional kinds of things that is recommended within the different articles on telling you the ABCs or the nuts and bolts of how to do these visits. They do recommend diet and exercise questions. Here are the 2 depression screening questions and one for anxiety, but have you in the past 2 weeks felt down, depressed, or hopeless, or have you felt little interest or pleasure in doing things? So there's that questionnaire, and you can actually go in and do the 9-question, the PHQ-9 as well. There's also difficulties with language, handling complex medical tasks. So if they have a hard time understanding even what that means, that obviously is difficult. Memory. Do you have any functional disabilities with hearing, or do you use hearing aids? What about other, here's the activities of daily living: bathing, dressing, getting out of bed, eating, and the like. Here are the instrumental activities of daily living: using the phone, preparing meals. And these are all standard, things that we've learned that are very useful to assessing in terms of function. Fall risks. And then down at the end, do you have an advance directive or any of these documents: living will, power of attorney, post form? Would you like to talk about end-of-life decisions? And then finally, list any medical care providers. So our patient will walk into the visit with all that. Our medical assistant will document that into the history of present illness section of the note. And I'm going to show you that right now. Let's jump into that. But as I am doing that, I want to let you know that we are, let's see, where are we? I want to go to a different patient. Let's go to Audrey Hepburn. ZZ Audrey Hepburn, I'm sorry. Not the other Audrey Hepburn. Okay.
And they can do it.
So who all here has heard of Patient Link? Raise your hands, a couple people. Patient Link is a form that can be, a bubble form that can be blackened during the bubbles, and then a scanner can review those results and actually place those answers into a V11 Allscripts note form. Meaning,
Get us one.
yeah, sign me
Not
up.
cheap.
So they're not cheap, but theoretically, with the reimbursement for these visits, this may be the way to get these scanners for more of the clinics, and we're thinking about doing this ourselves.
6 months of an MA salary.
But if you can take that form that I showed you, that the health risk assessment form that the patient fills out, and actually have it mapped to all the different boxes in this form, you or your medical assistant won't have to fill those out. But here is the form as it is now in the test environment. It's not available yet in live, but we're going to be using this probably very soon if it gets completely approved. But the form where you can document all of that, the health risk assessment, and all the fall risks and the activities of daily living, the advanced directives. And here's how you can put in that they have a cardiologist. We'll put in Dr. Smith as her cardiologist, and you get the idea. So, so what that what that ends up looking like then is that here's the history of present illness with all of that documented. And so if we can get a patient link form generated, hopefully in the next 4 months or so, where a patient can fill out the bubbles, we can scan it in, and it automatically populates all of this into a note. Won't that be a huge improvement? So that is one of the solutions to answer the question of what do I do since our medical assistants are already stretched? They can't do more of this work. Well, it gets to be to the point where some of these things, you have to ask yourself, how can we afford not to do these things? And maybe there will be more resources allocated to providing some of these services if the reimbursement is going to allow for that. So,
Lois, you had some troubles when you tried to pilot this.
It was
I'm not trying to.
it wasn't with.
It wasn't, this kind of a form is going to work because it's, the data is a point. The problem was when you asked them what kind of surgery have you had? And even if you check box appendix or brain surgery, you want more information, so it's actually better to have a MA question and then come up with the answer.
So
but this I think will work. I think it will.
Okay, so the question is, again, just to repeat the question, with these bubble scan forms, there's been some initial piloting of that to see if that would help. And so for a patient intake, a new patient who answers a question of what surgeries they have, well, their left arm surgery doesn't really help. But you need to know, well, actually it was a shoulder arthroscopy and repair of rotator cuff tendon. Well, there's no way that a bubble scan form is going to be able to allow a patient to find that choice and fill it in. But for discrete questions, and these questions apparently won't change, or if a few of them do, we can make some adjustments. But this is the information that we need. We can have the patient fill that out, and I think it'll be very helpful. The real question and challenge for the providers is to avoid the temptation just to gloss over this and not to actually look at what the patient's results and responses were, and to really be able to assist the patient for some problems. I caught myself today kind of just skimming and glancing over on a patient that I was doing this service for today. And there was a question that was in there that was very important. And I'm so glad I didn't just gloss over that and miss that opportunity. So that's the history of present illness note form for the Medicare wellness visit. But what about this plan for preventative services and other referrals? Well, obviously, if you're going to be referring them for other services, you can order within the system. But in order to order within the system, you have to have a lot of specific diagnosis codes at the ready. So let's say you want to do, the V70 is typically available, but let's say you also want to do the routine gynecologic exam. Well, you can assess that in the normal way that we do. I'll go ahead and unlock it, but as you're starting your note, you can go ahead and, again, this is in the test system, which is now the B1141. So if this looks a little different than what you're doing, just be aware that we're in that system. So if you want to add new problems, you used to go down here. But I wanted to demonstrate a concept that we haven't really used very much in Allscripts in our enterprise, but it's being used in a lot of other enterprises. And it's called an assessment form, where you can actually click a box, and it actually goes into the ACI, selects that diagnosis, and applies it to that encounter. So let's show you how that works. Let's say you've decided that, well, Audrey Hepburn is not a male, but let's say you want to do a colonoscopy. And so you want to assess this problem, visit for screening for colorectal cancer. And she doesn't have that diagnosis, but you want to be able to generate a colonoscopy referral order. So the way you can do that is you can just come to this assessment form and click this box. And you have just, did you see that little yellow commit button? Something's happened with the ACI. So let's go back up to the assessment section. And you can see right here, this has now been assessed as this problem. And now you can go into the plan and make your referral for her colonoscopy. And you know how to do that. You go into the plan section and do that. So let's look at some other assessments. So you can do this for any assessed problem, any ICD-9 code. So yeah, let's say you did want to do that AAA aneurysm screening. Well, you'd want to assess the screening for cardiovascular disease, and they have to have a diagnosis that they are a smoker. Either that they have a history of smoking, or they're a current smoker. So let's say that they're a current everyday smoker. Now you may have put that in your social history, but you didn't assess it as a problem. But Medicare requires that for the code to be paid for over at the radiology department for that ultrasound. So you put those two, and then you link both of those to your abdominal ultrasound, and it gets paid for. So there are several of these screening services that do require special codes. If you want to get crazy with how Medicare set this up, they have one for influenza, one for pneumococcal, a different one. But what's interesting is if you want to give both the pneumonia and influenza, if you do both of these, they will throw that out. They will not pay for it. But if you assess this single additional code that is only good for Medicare for vaccination of both influenza and strep, then they'll actually pay for you having given those two vaccines. Go figure. You have to really keep your wits about you when you are billing for Medicare. And so this tool not only allows you the ease of assessing those problems without going into the ACI, searching for those codes, and clicking them, and then getting out of the ACI. So this helps with actually assessing those problems. But it also was found in the other enterprises that are using this as a teaching tool for the providers. If you want to go ahead and give these screening things, here's how you do it. So again, you can say that the CPT code for the prostate cancer screening. Well, there's a digital rectal exam, and you need to build G0102. And if you do a PSA, the lab has to, you need to make sure that the lab has that V7644 and that they build the G0103 code. Well, so again, the idea is not only just to be able to assess the problems, but to be able to teach you with the information that's there to be able to know how to order these things and get them paid for. So finally, just real quickly, and we're wrapping things up, is that with the plan section. So there is now a plan for you to document all of these preventative services. So let's say you do want to add a few more things. So they haven't had any glucose diabetes screening lately. So you want to check a fasting glucose because they have hypertension and hyperlipidemia. and their sugar was 105, so it's a little bit high. So let's go ahead and say we recommended that every 6 months we check a serum fasting glucose. And so this form in the plan section of the note, called Annual Wellness Visit Preventative Services, will allow you to document in the plan. So let's show you what that looks like. So here's their preventative services recommendation that will print off on the clinical summary. It prints off automatically when you give the clinical summary, and so that I think is the most helpful location to provide the patient with this information. And these are the appropriate screening recommendations. And you'll see that what it says is DEXA recommended every 2 years, and since we're doing one now, I just ordered it. Your next one is going to be due in October of 2015. And annual wellness visit, I recommend it every year. We did one this year. I recommend you do it again next year. Same thing with diabetes screening, recommended every 6 months. Oh, we didn't put when they're due next, so that'll be in, April of 2014. Okay, do you get the idea? So that is the plan section that will allow you to meet that requirement for the medical annual wellness visit. Nothing easy about this. We are working hard to try and make sure that this is linked up with medicine terms so that we can kind of get credit for some documentation. This does not order the mammogram. It just merely gives the patient the understanding, right now, this is the easiest way to do this, of when their recommended screening schedule should be. In the future, we will learn how to order a mammogram alert. You need one every 2 years, or and so you may end up using more and more of those orders instead of this documentation. But at least somewhere you need to be able to provide them that information. Does that make sense? So those are the main components of the Allscripts documentation tools and that health risk assessment. Stay tuned for the patient link form, the bubble scan form. We're hoping to pilot this starting maybe at the end of this month, beginning of November. So if you are wanting to schedule those, I would really encourage you to talk to either your administrator about moving forward on that and how to set that up. I think you'll probably be hearing some information from the center's administration team, but kind of getting these things worked out in your office in terms of your workflow and who's going to do what, I think is going to be important for you to work those out. Questions?
Yeah, I was just wondering, who's dictating those guidelines? Is that?
Oh, that's a good question. Okay. So these are fairly standardized, allowable preventative services according to Medicare. Now, the majority of these guidelines were whatever falls under the U.S. Preventative Services Task Force. And there are A recommendations and B recommendations for preventative health and screening for seniors. And so Medicare took those and provided for those. The only ones that are allowable by Medicare that are not A and B recommendations is the PSA. So PSA has gotten a lot of negative evaluations lately under U.S. Preventative Services Task Force, and it'll be interesting to see the status of PSAs, but for right now they are paying for yearly PSAs every 2 years for pap smears. So you do have to kind of, decide what you want to do. Now, I have some of my patients who know that they want their annual visit, their well woman check, everything done every year. Medicare pays for it every 2 years to have their pap test, but they want it done every year, and they're happy to pay for it as long as they sign an ABN form, an advanced beneficiary notification, to say that they understand that they'll be responsible for the bill. We go ahead and do that service, and then the bill comes to them. But and so then it is appropriate to put a pap test every year. But most of you are, and I think it's appropriate to do every 2 years for the pap test for seniors up until a certain age, and then they get to graduate and not have to have that unless they're having some symptoms or whatever. I don't know how you manage that. But so realize that you are responsible for maintaining the guidelines. I do have a 2011 Medicare Preventative Services screening list. And so, I don't know, do we have out here I didn't put it out yet, but I want everybody who wants to have more information about this to give me their email addresses. So I'll pass this around. Go ahead and put your email address, and I will send you probably about 10 different documents regarding how to do Medicare wellness visits. It'll include that patient questionnaire. It'll include screenshots of these Allscripts notes. It'll include the 2011 Preventative Services Guide so that you can see what the actual guides are and whether the test is waived, and typically what the diagnosis code is. For some things, you can do a lipid panel every 5 years for all asymptomatic beneficiaries. Well, it's not every year, is it? You need to know that because the patient will have do that. But also something a help for that is the this new I believe it's called eligibility checking. Is that the new term?
Yeah.
That we are going to be told that this cholesterol panel is not due because you are assessing it for cardiovascular screening. They don't have hyperlipidemia or hypertension. It's cardiovascular screening. And they had it done a year ago, and so they're not eligible for that now. And so they have to sign an ABN if they really want to go ahead and have that still done. So that's what eligibility checking is going to benefit us, because we'll be able to counsel our patients. Well, you're going to have to pay for it. I'm happy to order it, and I think it's probably a good idea. So let's do it. And but you'll have to sign an ABN, and your medical assistant can bring that in. So, okay, what other questions?
I'm just wondering, because I guess this is mostly for the patient's benefit and perhaps our benefit looking back to look at the dates. But for the pap smear, for example, it's every 2 years in general, but there's a specific set of qualifications of people that can have it annually. Where do we
Yes, high risk.
How
Yes.
do we?
Well, that's why this form was designed to have some flexibility. So if we were to go ahead and clear this form, let me clear this form so you can see how it looks out of the box.
So
Okay.
basically, you can put in all the different
Can you
frequencies.
put
Okay.
in pap smear every 2 years?
Yeah.
Yeah, here's where you can document pap smear. And actually, this needs to be cleaned up a little bit, but you can put every 1 year,
So you
every
can
2
put it
years.
in there.
Yeah. And then you can put the date that it's next due. So 10, 12, 2013, or 2015.
But is there somewhere else you would document why they're having it every year so that it gets paid
Yeah.
for?
Well, you certainly can do that. Because again, and I didn't put it in this Medicare wellness assessment, but for cervical cancer screening, where did I put that?
Pap smear visit for smear.
Oh yeah, here it
That's a
is.
high-risk screening. That's not just the routine, that's high-risk.
Yeah, okay, so here's the one that you would want to check then, wouldn't you? This is the visit for screening, high risk. You click this box.
No, that's for
Mammogram.
mammogram.
Oh, I'm so
You put
sorry.
down the pap smear.
Is this the V76.2? What did you say this was the high risk?
That's the high risk, I'm pretty sure.
Um,
Code.
Possibly. I do know that there is this one, the routine gynecologic exam, V7231. That's the one that you're typically using.
That's
So
for
if
the
they are
younger
high
one,
risk,
then it's
I should
V76.
actually put that in, but if you look at CPT, this is the actual description, is visit for screening. I think there is another high risk, and what I'm probably going to do, this is a really good
Is that it?
suggestion, is that I'm gonna make the term, the readable term for that code, say what it should mean, and if there's a high risk one, then you can assess that and then order recommended every year.
And then the other question I had is in the scan-in patient form, this may only be my patients, but a lot of them put incorrect information on it.
That's correct, yeah.
So what do we do about that?
Okay, so the question is on the scan form, and pretty much any form that a patient gives back to you, they may put information that's not correct. And in addition to that, just to kind of expand our conversation, patients will tell you information that is incorrect. Have you ever had any surgeries?
Really?
No, never had any surgeries. Oh, except for the vasectomy that I had done. And and that's right, I had my appendix out. And so, no allergies. But 20 minutes later, then they remember that they had a penicillin allergy. So you're right. The form is a tool. And the requirement of effectively using the tool is knowing what its benefits are, the good uses of it, but also knowing how it can hurt you, right? So if you want to know how a circular saw can hurt you, I think we all get the idea. But it can be a very effective tool. So some people who know how to use it can effectively use a circular saw. I'm not very good. I stay away from the circular saws most of the time. But every now and then it's just a little exciting to go ahead and break it out. Well, so in terms of this tool, this Scantron tool, it is something where you have to be aware that as you are reviewing the data, it may not have come across correctly, or maybe the information is actually incorrect because the patient checked it wrong. So, you have to be aware of that.
You still have to go through.
You have to edit it.
Yeah.
And then, but that is the idea is that in the history of present illness form that has been populated by the patient bubble form, you can still go in and even edit all of those answers.
So, and I guess it doesn't matter as long as the correct information gets in there. Like now when they do it on paper and they put, have you ever had an abnormal pap? And they put yes, and I talked to them about it, and it's because they had chlamydia. Their pap was perfectly fine.
Right.
I can make a little line and write that next to it.
Correct.
So it's clear that they put that, but I corrected it with this information.
Good, yeah, very good.
Is there a way to do that
That's a
in
good
there?
example. Well, that specific question is not a part of this form, but if they said, well, yes, I do have a living will, but actually it's just the pulsed form, where you can unclick the living will and you can click the pulsed form and correct that addition. Good questions, yeah. So I don't want to go too late. We're all have had a long day and probably have a few more things to get ready for our go live. So I just want to thank everyone's participation. I will be around for several minutes to go over and answer other additional questions, but I want to just formally close our night and say thank you to all of you and for your participation. And we're looking forward to probably another wrap up. I did want to, we'll talk about this offline, but we're probably going to be doing another one of these user group meetings as a circle back for the 11.4.1 go live. And we may, it may be decided that we will do this not at the end of the quarter of next quarter, but maybe in another month or two. Okay, so stay tuned for that, and thanks again for everyone.